Harold J. Phillips holds a master's degree in urban and regional planning and played a pivotal role in the U.S. government's response to HIV. Between June 2021 and January 2024, he led the White House Office of National AIDS Policy as its director, steering the Biden administration's approach to domestic HIV/AIDS issues. His responsibilities encompassed overseeing the national HIV/AIDS strategy, liaising with various governmental bodies such as the Office of Management and Budget, the Domestic Policy Council, the National Security Council, and the Office of the Global AIDS Coordinator. His efforts were centered on enhancing America's strategy against the HIV epidemic, focusing on reducing new transmissions, improving the lives of those with HIV, and striving towards ending the epidemic. Before his tenure at the White House, Mr. Phillips was the Chief Operating Officer for the Ending the HIV Epidemic initiative at the U.S. Department of Health and Human Services, under the Office of the Assistant Secretary for Health. There, he coordinated the initiative's activities across different operating divisions of the department. Mr. Phillips' earlier career included significant roles at the Health Resources and Services Administration's HIV/AIDS Bureau, known as HRSA-HAB. He served as the office director for various programs, including the Ryan White Program's AIDS Education and Training Centers, or AETCs, Special Projects of National Significance, or SPINs, and initiatives funded by the U.S. President's Emergency Plan for AIDS Relief, PEPFAR. Additionally, he was the deputy director of the Ryan White Part B and AIDS Drug Assistance Programs, or ADAP, collaborating closely with program recipients, planning councils, providers, and patients. From 2003 to 2010, he was a member of the CDC AIDS Advisory Committee, or CHAC. Phillips also contributed to public health at the state level, working for the state of North Carolina in the Department of Health, Environment, and National Resources. He was instrumental in establishing the state's Housing Opportunities for People with AIDS program, or HOPWA, in 1993. Harold is an alumnus of the University of North Carolina at Chapel Hill and Kalamazoo College in Michigan. And Phillips is also an individual living with HIV, bringing a personal perspective to his professional endeavors. And with great appreciation, I now turn the floor over to Harold Phillips. Next slide, please.
Thank you, Mark. And good morning, everyone. It's very nice to be here with you. I want to thank the National Working Positive Coalition for this invitation, and also importantly, North Carolina Central University, in that you would invite a Tar Heel to participate. So thank you so much. I'm going to talk a little bit about the importance of addressing the employment needs of people living with HIV and its connection to our national HIV/AIDS strategy, which the federal government had released in 2021. I'm also going to leave some time for some Q&A at the end of this as well. So next slide. I think it's important just to set the context of where we are in the United States with HIV today. Very often in my previous role and position, I encountered people who felt like, you know, I'm not hearing a lot about HIV, or I thought HIV was over. And so I really like to sort of set the context of where we are in the United States today. With about 1.2 million people living with HIV, 13%, or nearly 1 in 8, have not been diagnosed. Of those that are living with HIV and diagnosed, only 57% are virally suppressed. And I'll talk a little bit more about that and why that's important as well. We have had just over 34,000 new infections occur annually. So we sort of had plateaued. This was the impetus for a new initiative like the Ending the HIV Epidemic Initiative, and also one of the reasons why President Biden felt that it was important to start an Office of National AIDS Policy back up again after the previous administration had gotten rid of it, to really help us reduce those numbers of new infections and really focus the effort along with additional resources to be able to do this as well. If we didn't do anything and we just sort of left it level, we'd have another 400,000 new infections by the year 2030. Next slide. We have also, in the United States, both declared and embraced this, and we've been embedding it in a lot of our materials and our approach to the HIV epidemic. When someone enters into treatment and achieves and maintains what we call an undetectable viral load, meaning that the level of virus in their bloodstream is so low that they cannot pass it on to their sexual partners. So treatment, so this becomes both a motivation for treatment and empowerment, and also a destigmatizing message. So we have fully embraced this in the United States and also around the world. And we are working to make sure that this message gets out there, not only to people living with HIV, but to the general public as well. Next slide. I just want to touch on the social determinants of health, which are those non-medical factors that influence health outcomes. And they include the factors and conditions of where people are born, where they grow up, work, where they live, age, and the systems that shape the conditions of daily life. Very often, these social determinants of health have an influence on the health outcomes that's even greater than what happens within the medical setting. These factors have been categorized into several groups, such as income, education, job security, employment, working conditions, childhood development, food security, and health services. We are paying much more attention within both the federal policy space and the program space on the social determinants of health. The administration has also released what they call a social determinants of health playbook that instructs both county, state, and local governments, and also community-based providers on the social determinants of health and how they can think about braiding some of these services, which, as you look on the screen, these are not necessarily what we think of when we think about health services. But there is a need to braid funding and resources in a way where we can meet individuals where they are, address the social determinants of health, and help them achieve greater health, overall health and health outcome, health, wellness, and health outcomes. Next slide. The social determinants of health are important, and they also show up when we are doing surveys or needs assessments, or we look at what some of the issues are that might cause someone to fall out of care or stop taking their medication. And if you look at these are sometimes, I refer to them as life happens: unemployment, food insecurity, homelessness, incarceration. On a study that was done by our CDC colleagues, the Medical Monitoring Project, looking at some of the issues and situations of people with HIV, they found that 41% documented unemployment as an issue and as one of the social determinants of health that was impacting their ability to stay in care. So all of that I put out to you both, sort of nationally, where are we with the HIV epidemic? What's happening with the social determinants of health? And sometimes you'll hear people talk about intersectionality. Well, that intersection is the intersection of these issues along with healthcare. Next slide. So on December 1st, World AIDS Day of 2021, President Biden released in the East Room of the White House a new national HIV/AIDS strategy to help guide our efforts toward ending the HIV epidemic in the United States. And with that strategy, really, and the thing I really want people to emphasize, and why I'm very excited that my North Carolina Central colleagues are involved and engaged in this, it's not just a federal strategy. It's a national strategy because it includes things that the academic community can do, the faith-based community, community-based organizations, private sector businesses, along with the federal government, can all do to help us end the HIV epidemic. So it doesn't just outline what the federal government is going to do, but it has a place and a space for all of us to see what we're doing. And so again, I applaud North Carolina Central for the work that you're doing on this particular topic. Next slide. The strategy itself has an overall vision, 4 goals, and each objective for each goal, and strategies to help us reach and achieve those objectives. It also uses data to identify our priority populations here in the United States that are impacted by HIV, so the communities where we need to focus some of our attention, our efforts, and our resources. And so that it just doesn't become a well-designed federal government that sits on a shelf, we also have indicators of progress so that we can hold ourselves accountable, not only ourselves as the federal government, but also the nation for achieving these goals. And they will be looking at where we are with those indicators of progress as well in the next year or two. Next slide. Some things that we are, well, I would say some things that I'm really happy about and proud that the administration included in this strategy is recognizing that racism is a serious public health threat, and being able to say that in the strategy and call that out and call it the impact of systemic racism on both access to healthcare and retention in healthcare. I have frequently said that our system of healthcare doesn't work the same way for everybody. And so we have not achieved our overall goal. And some of that is because of racism. There's a new focus on people who are aging with HIV. Over 50% of the Americans with diagnosed HIV in the United States are over 50 years of age. By the year 2030, over 70% of the people with diagnosed HIV in the United States will be over 50 years of age. So this piece of aging and HIV, now that could be scary, but I also throw it out as a challenge. People with HIV have helped reform our healthcare system in so many different ways. And right now in the United States, we don't deal well with aging. And so I'm hoping that as advocates, as researchers, people who care about people with HIV, that as we continue to age, we will reform the American health system to be able to better meet the needs of populations who are aging, that will also be aging with us or might come after us. Strategy also talks about a syndemic approach, looking at the intersection of HIV, viral hepatitis, STI, substance use, and mental health disorders, and thinks about strategies and objectives that talk about sort of that intersection and ways to address them. A greater emphasis on harm reduction and syringe programs, and an expanded focus on the social determinants of health, which I talked about earlier. Next slide. So on the next slide, you will see the priority populations that are both based on our incidence, our diagnosis, and our viral suppression data. And so thinking about and looking at those populations and thinking about sort of where they are within your community, I think will be really helpful as you think through some of these issues. All right, next slide. The strategy also includes quality of life measures. We had heard from the community very loudly that they are more than just their lab values. and especially with individuals living longer with HIV, was need to look at quality of life. And so we embarked on a task of thinking through how we could measure quality of life for people living with HIV. What would that mean, and how can we share? How can we really and truly, I think, open up the federal space and our programs to really hold ourselves accountable? You'll see on the screen those quality of life measures that also include employment status. The other thing about the quality of life measures, it also signals to our other federal programs that it is important to not only collect sort of the lab values, but to collect information regarding the quality of life indicators as well. I think one of the things that's on my list of things that I'm most proud of is that I believe that the United States is the first country to adopt quality of life measures for people living with HIV as we go this direction. Someone said to me last week and this week in one of my going away meetings or parties that I have expanded the understanding of the federal space and their programs about the lives of people living with HIV, and have signaled that this is important by being able to document this as part of our national strategy. So next slide. So again, employment status being one of those really important quality of life measures. And the employment benefits for people living with HIV are very clear, and the research talks about this. And I know you're going to get into some more of this in some of the sessions as well, about what does employment do for individuals living with HIV, and some of those things are here on the screen in terms of better access to healthcare. Many employment opportunities come with access to health insurance. And so that is extremely helpful. Psychological and the social benefits of employment. And I think we all sort of saw that, even those of us who might have been employed and stuck at home, we missed that sort of social aspect of being together and being with individuals and learning and just sort of socializing. Reduce stigma around HIV and improve mental health, and also an overall sense of purpose that comes with having a job where you are actively and meaningfully contributing and feeling that as well. And also being rewarded and being paid for what you put in also makes you feel good. It makes you feel like a sense of purpose. Next slide. And like I said, there is research that backs all this up, and I know that you all will be talking about some of that as well. I think the other thing that we have to think about is also, what are the benefits for employers who hire people with HIV? As I said, many people with HIV are over 50 years of age, so it's a mature workforce. Not to diss our younger workers, but there is something that comes along with age and wisdom and some experience that you will also get from people living with HIV. Also, given what I said about priority populations, they are a diverse workforce. So companies who are thinking about diversity and inclusion, including people with HIV as a pool of potential employees, means that you will have access to a pool of diverse workers. Many often have already acquired certain skills. I love being at some of our national HIV conferences and hearing about the backgrounds and experiences of many of our advocates who have been doing this work, and the things that they've done in their lives and over their careers, and the skills that they have. And also for many people who have this opportunity to re-enter the workforce, or to continue in the workforce, or to gain new job skills, they're often motivated as well. So I think we have to think about two sides of the coin. What's the benefit for people living with HIV? And what's the benefit for employers who hire people living with HIV? Next slide. So why isn't this happening on a more regular basis? We have healthcare and vocational services programs. They're not integrated. We talk right now, we're at a point in the United States, like I said, where we're talking a lot about the social determinants of health, but that integration and that braiding of the services isn't necessarily happening. Many of our HIV case managers are not trained to link vocational services or aware of vocational services resources. And so they're not screening for that need when they're looking at other needs during sort of intake or thinking about eligibility. Secondly, many of our HIV planning groups don't prioritize or fund vocational case management, even though they could, especially the Ryan White planning groups. It can be funded as non-medical case management. But I think that using a data-driven approach, they could be funded and prioritized, not only under Ryan White, but as part of the Ending the HIV Epidemic Initiative. So that funding stream, along with the Minority AIDS Initiative funding stream, could be used to fund vocational services, especially when we've got documented need and we've got the research that says that these programs make a difference. And if the research is saying that these programs also can help with viral suppression. As I said earlier, the United States has a viral suppression rate of 57%, one of the lowest in the Western world. And some of it is due to income inequality, poverty, and a lack of employment. Third reason, vocational services programs are not aware of the HIV services network. Many of those programs funded from the Department of Labor or the Department of Education aren't reaching across the aisle to HHS programs, where our HIV programs sit, either funded through Health Resource Services Administration, the CDC, SAMHSA, or even NIH. So we have these silos that have been created out of Washington where our funding streams go to different departments and our programs don't get the opportunity to come together and think about. Very often we're working in the same populations and same communities. Outreach across the programs at the state and local level is needed, and it takes time and effort. I was just here in Prince George's County, just held what they called a status neutral meeting, thinking about HIV testing and linking individuals to needed support and social services as well as health services they may need. I was absolutely thrilled, over the moon, that there was an employment services provider that was there and had a table where individuals could meet and talk with them and talk about their programs and talk about jobs that they had that were open and available and how they work with different employers throughout the county to be able to connect those who are unemployed. And they wanted to do more in the HIV workspace. So I think those kinds of community fairs, I think fairs that perhaps people living with HIV groups have, we need to think about employers. I think some of those meetings or conferences that we might have at the state and local level, we need to ensure that we're reaching across and making sure that vocational service programs are at the table. Then lastly, there's still a lot of HIV misinformation, a lack of information about HIV as a chronic disease. So someone with HIV can work just as well as someone with high blood pressure or with diabetes, someone who is working in care, taking their medication. Many people with HIV want to work. I think it's a artifact of where we were back in the very early days of HIV, when an HIV diagnosis meant death, and also meant many people went on disability and didn't work. But many people with HIV want to work. And I still think we still have work to do within this country about HIV stigma that also can be addressed when many more people are out about their status and doing the work. I mean, one of the things about my previous position is that people said, you know, I serve as an image of what is possible. Like, here's someone living with HIV, working in the White House, working long hours sometimes, often, but also really and truly being an example of what is possible, and being that beacon of both hope and light for others as well. Next slide. And I'm almost done here. So The other thing I want to say to you all, because now I'm not a federal employee, so I can encourage you to advocate. So let your voice be heard. Federal, state, and local lawmakers need to understand this link between health and vocational services. Part of, there were times when, even I heard from people inside the Department of Labor who care about these issues, that it's an uphill battle to get their officials to understand this connection and why it's important. I think also, I said federal, state, and local, but I would say also Congress needs to understand this too. So as you're advocating, make sure that not only are you going to the Hill and talking to the Labor HHS committee, but also make sure you're talking to labor about labor issues. Make sure that, when you are meeting with your state and local lawmakers, you talk about this as well. There's a lot of education that needs to happen with our HIV planning councils so that they can have both the research and the understanding about vocational services and its role in not only helping improve viral suppression, but quality of life overall. We need to be able to share models across jurisdictions. Like I just talked about what happened this week in Prince George's County. We need to share other models and examples of how this can be done as well. The other thing I would say is we need to move research into practice regarding employment. So there's I'm pleased that there is more research that is coming out that is proving the point and some of what some of us already knew about the role of employment services. Now we need to move that research into practice. And so I'm a big fan of speeding up research. Like I used to tell my friends at the National Institute of Health, if you today had a really great idea, and then by the time you get that really great idea funded and people are actually providing that care, it's 2 years. And then if you want to study it for another 3 years, now we're at 5 years. And then it's going to take another year for you to write up all of those results. That good idea that you had is now 7 years old. It's not a good idea anymore. So research needs to move faster to get into practice for us to really and truly move the needle with some of these innovations. So I'm a big fan of putting out promising practices, best practices. I don't necessarily need 5 years of research. That's evidence informed, evidence based. I don't need it to be that sort of rigorous because right now many of us are trying to get it done by 2030. So that's not 7 years. People living with HIV groups in counties can hold the informational fairs and include vocational services providers. I think it really and truly sort of makes a difference. And I sometimes tell the story of once I was working in Phoenix and the people with HIV group decided that they were going to have a services fair for people living with HIV. So we got space at the convention center, we set up tables, and we had invited a lot of service providers and all the rest. And someone had the bright idea of reaching out to the housing department and saying, would you come and set up a table Saturday noon to 4? The woman from the housing department showed up and she said, oh, I'm so glad somebody called me because I have all of these spaces in Section 8 and I didn't know anybody in the HIV community, and I thought you all might be interested. I've got applications in my car. Let me tell you, she couldn't get that box out of her car fast enough because everybody ran with her to the trunk of her car and started like taking applications out of the box. And I was like, wait a minute, we got to get the box to the table. So I think those phone calls, that outreach, people can do that. And that's not a heavy lift, but it's such a simple thing that's not necessarily happening. The other thing is encourage local employers to adopt inclusive employment practices that include people with HIV. This is really important because especially as we, talk about, the job market is becoming more tight. Oftentimes they haven't thought about us. They haven't thought about people with HIV. And so I think talking to your local businesses and employers is also an important strategy. But I'm going to say it one more time because now I can. Let your voice be heard on this issue. We need additional advocacy around these issues because, like I said, it's a lot of folks don't understand it and don't get it. but it makes so much sense when you think about when you have meaningful employment, what it does for you as a person, both individually, for your family, for your community, for your overall health and well-being. Next slide. So the National HIV/AIDS Strategy, like I said, includes all of us in our nation, all sectors of society to be engaged in this coordinated, re-energized national response to HIV. On World AIDS Day this year, Dr. Fauci said, we have all the tools, we know what we need to do to end the HIV epidemic. Between treatment, between prevention, we just have an implementation problem. I would add to that, we have an implementation and an equity problem that could be solved if we look at employment differently. Next slide. And that it's going to take all of us together to think about how we do this. And I'm really excited and encouraged by this forum, and we need to have more forums like it. So thank you all. Thank you to the organizers, and thank you all for being here. And I'm so glad my voice held out.
Oh, Harold, thank you so very much. I think we could have time if anyone, I don't see if any hands raised currently, but want to give a call for a possible question, possible comment. I did not see a question in chat. I just want to say, Harold, how deeply appreciative we have been throughout the years of your extraordinary tenure at the Office of National AIDS Policy, for your partnership, for your spotlight that you have shared with the need for strengthening responses to the employment needs of people living with or at greater vulnerability to HIV. Let me just double check. Harold, thank you so much for joining us today so soon after the maelstrom of the final days of your time at ONAP. We greatly appreciate it.
I think there's a question in the chat. Hey, good morning.
Hi, Liza.
So thankful and so grateful for your message.
Thank you. Mark, let's see, is there a message?
Let's see.
Did you find it?
Have people become
Yep.
Yes, Kyla, thank you.
No, I was just going to say, have people become more open-minded regarding HIV over the years, or are people forgetting about the movement?
In my experience, I have found people forgetting about the movement. Not those who aren't sort of working in this and doing it every day seem not to hear about HIV as much. Last year, I was at Paramount Pictures and talking to them because I think it's for the first time within, I want to say at least, it's the first time on network television that we don't have any openly out HIV positive individuals. And I talked with them about sort of the role that media plays. And some of the gains that we have had as a movement had been because of media. I think too, the other thing is that there are not conversations about it anymore. I think as it has faded into the background. I think also, you know, when I talk about one thing that I point out in the strategy and in my list of priority populations, we highlight Black women. And this is another area where I feel like people don't know about the impact of HIV on Black women in the United States. And we were very purposeful and deliberate. We could have said women, but that would have masked what the data is telling us. So we specifically called out Black women to start a national conversation, which is happening, about what's going on in the Black community with regard to women and HIV. And one of the things that I have experienced is when I talk to people about the data and I talk to them about the increased rates among Black women, people always turn to me and go, I didn't know that. So the conversations aren't happening. And so that I think is a big part of it.
Harold, thank you again so very much.